Hello, everyone, and welcome to today's District Administration web seminar, which is entitled Combating the Youth Mental Health Crisis by Expanding Equitable Care Access, which is brought to you by the generous support of our sponsor here today, Hazel Health. Now, before we get started, I'd just like to share just a few housekeeping items with you and we'll get started. If at any time during the presentation today you might need technical support, please just use the chat panel, which you can access by going to the lower right-hand side of your screen. Then select on my name, which is Stephen Blackburn, and then just type in your message and I'll get back to you as quickly as I can. If for whatever reason you don't have computer speakers, or maybe you prefer to listen privately, just look again to the chat because I'll be submitting a phone number and access code there so that you can dial in. So look out for that. We will also be welcoming any questions you have here today at the end of the presentation with a Q&A session. You can submit a question at any time by using the Q&A panel, which you can locate at the bottom, again, right side of your screen. Then send your questions to all panelists and we'll answer them live after the event. If you currently don't see the chat or the Q&A panels, again, look to the bottom right-hand side of your screen, then just click on the expand triangle, which is located directly in front of the panel name. Also, the last thing I'd like to say before we begin, if you would like to access the webinar at a later time, you'll be pleased to know that everyone who is registered and especially who is attending today will receive an email with a link to the slides and an archive recording. And with that, it is my pleasure to hand things off to our moderator today, Dr. Travis Gales. Hi, Travis. Great to have you with us here today.
Good morning, and thank you, Stephen, for the introduction, and thank you all for joining us today. On behalf of the Hazel Health team, we'd like to welcome you to today's webinar, where we will be talking about an extremely important topic that has unfortunately grown to significant levels and received lots of attention from the national level. But it is a topic that we know that many of you know firsthand and know that has been present and plaguing our young people long before COVID hit our society. Today's topic will be looking at the youth mental health crisis by expanding equitable care access, because we know that even though the need is significant, there's still significant concerns related to the shortage of providers. And in our efforts to address this, we want to make sure that equity is a part of the conversation in determining and developing solutions. Next slide, please. So today you will hear from two distinguished individuals who will share their personal stories related to their work, the ongoing work in their respective jurisdictions. And just as a flag, my name is Travis Gales. I'm the Chief Health Officer for Hazel and excited to be here with you today. Next slide. As I mentioned in the early comments, this issue of youth mental health needs and crisis predates COVID, but we know that once we've hopefully are moving through COVID to the other side of things, that we have a significant national mental health crisis on our hands. During the pandemic, depression and anxiety in young people and youth doubled compared to pre-pandemic levels. And more than 140,000 children in the United States have lost a caregiver due to COVID-19. In October of 2021, the American Academy of Pediatrics declared a national emergency in children's mental health, noting alarming increases in depression, anxiety, and suicidality experienced by children since the onset of the COVID pandemic. And in December, the U.S. Surgeon General issued an advisory warning on youth mental health after indicators showed alarming increases in the prevalence of certain mental health symptoms. Next slide, please. Now, putting this all together, one of the big challenges is we know that we have significant need, but how do we begin to address it? Schools have been asked and required by their state legislatures in many areas of the country to develop programs to assist and address mental health concerns. But we know that administrators are asked to do this in the face of significant shortage of counselors and therapists available. And in looking at this slide, the data confirms that 60% of our children don't receive currently adequate mental health services due to a host of different barriers affecting the availability of services, whether that's looking at the shortage of counselors and therapists available in their respective locations, access to transportation, appointment availability, etc. And 50 to 80% of those who actually are fortunate to receive services at this time receive those services through their schools. So the school is an important place and an important resource in helping address this mental health crisis. But again, we know that resources are limited in helping schools be able to address these concerns. Today, we're going to hear from two local experts about the work that they have done to address the mental health crisis in their respective jurisdictions, using the school as a conduit and major resource to accomplish those goals. Next slide, please. I'd like to turn the floor over to Superintendent Fred Hyde from Polk County Public Schools in Florida.
Good morning, everyone, and thank you very much. It's a pleasure to be here to talk about this with you all today. If we could advance to the next slide. I am Fred Hyde, Superintendent, Polk County Public Schools. We are currently the second fastest growing county in the nation. Our current enrollment during our current year is roughly 110,000 students. Our projected enrollment for next school year, just to give you an idea of the growth, is 116,000 students. So we are growing leaps and bounds. And with that comes a commensurate level of need and support, which led us to kind of explore this opportunity. So for those of you who don't know where Polk County Public Schools or Polk County is in Florida, if we could advance to the next slide. Polk County, historically, largely agricultural, rural community. Many of you may know it if you either flew into Tampa or flew into Orlando and you were going to Disney or going to Tampa. You typically drove through Polk County Public Schools or Polk County generally. However, due to our growth and our expansion, Polk County is emerging and moving away from agriculture and largely has become a logistics hub for the southeastern quadrant of the United States, which has helped spur some of our growth. We are a bedroom community to both Orlando, Orange County, and also to Hillsborough County and Tampa. Next slide. Again, we service currently about 110,000 students. As I shared, we're growing very quickly. Some of our schools are enrolling an average of 2 to 3 students per day, new students. And so we are, again, experiencing commensurate and explosive growth. We have 150 plus public schools. Additionally, outside of that, we obviously have some charter schools and some private schools. We are averaging right now an 86.5% graduation rate. That's up 10 percentage points from just 2015-16. So a lot of great progress has been made here. And we are the 7th largest school district in the state of Florida and the 29th largest school district in the United States. Next slide. Quick snapshot of our student demographics. Again, as I shared, Polk County is a county in transition. Our growth has also resulted in a significant shift in our demographics, and we're starting to see that play out in our student demographics. At this time, 62% of our students who are enrolled are students of color. 14.6% of our students are students with disabilities, and 9.5% of our students are English language learners. And so while we are seeing a very large shift in our Hispanic population and growth in that area, we're not necessarily seeing a large growth within the population of first-year newcomers or EL students, LY1s. Next slide. So really, as a school district, one of the reasons we looked to this was I had previous experience as a superintendent in Illinois, where we launched a program with someone else, really largely based off Kaiser Permanente's study about adverse childhood experiences and the recognition and acknowledgement that early childhood trauma, if left unresolved and unsupported with a lack of supports, actually serves as a legitimate barrier to learning. Students who are in constant turmoil, constant flight, do not have the aptitude, skill sets, or strategies to basically de-escalate situations and to be productive and to truly engage in a school setting. Based on that, in my arrival here in Polk County, having lived through the first part of COVID in Illinois and then taking over here throughout this year, we saw increased need. We continue to see more and more students, behavioral issues manifesting as a result of students being in crisis. Many of us and many of you on here coming from school districts, you've seen more than likely your student discipline cases and or requests for mental health supports more than double this year alone. And so there was a clear identification of need for us. One of the reasons we chose to go with an outside provider, number one, philosophically, I believe our core business is education. And to a certain extent, we are very good at providing low touch, low demand wraparound service supports for psychiatric care, social work, and others. And oftentimes we have heavily relied on outsourcing or referral processes for students, which the problem that we now face is a staffing challenge. There's a shortage across the nation of SLPs, BCBAs, and other mental health support staff. And so as a school district, we recognized, again, our core business is education, and we wanted to partner with an expert who had the staff that could more adequately support our needs of our students and our families. We also recognize that here in Polk County, and many of you would be surprised in your respective counties or school districts to find that the waiting list for children in particular to be able to get an appointment to see someone for mental health and or physical health, especially in the midst of COVID, and thankfully hopefully we're on the tail end of that, is right now for mental health services in Polk County, there's a 7-month waiting list for appointments. And then for physical health, a lot of our issues, we actually had physicians here basically refusing to see students and telling families that if they had the symptomology, they should just assume that they had COVID, and that if their symptoms, persisted after 5 days, that they would then schedule appointments. Now, take that into consideration, the overwhelming nature of COVID and how the volume of cases was overwhelming our local healthcare system. Now add 6,000 potential new students and families into the mix. And that's just our side of it. That doesn't include all residents coming into Polk County. There just weren't enough resources available for our families. And so we needed something to be more proactive and give our families something that would facilitate and readily support their access to healthcare and mental health supports. Obviously, we all recognize there's a strong link between social emotional well-being and academic performance. Again, having had a background with ACEs and having seen a program be successfully implemented in my previous district, where we were able to essentially after year one eradicate absenteeism, hospitalizations, and at the end of the year, those students who were in that pilot group that were receiving supports were actually performing at a commensurate level as their peer group after just 1 year. So we did know that with strong supports, especially with mental health supports such as cognitive behavioral therapy embedded within the school day, that we would see strong outcomes. And based on that, I looked for this opportunity coming into Polk County. And the reason we chose Hazel, for obvious reasons, they had both the integration of mental health and physical health. For our families, we liked the fact that Hazel provided not only access through signature, or through permission slips for our children and students to participate while at school under the direct supervision of either a nurse or a counselor. But we also like the fact that Hazel extended that opportunity for our families to participate at no cost to them. They could actually do so before school hours and after school hours. And so for parents who were reluctant to have their children engage with a physician in a virtual environment or a mental health provider in a virtual environment outside of their purview, outside of their direct access to their child, in that situation, we found that support to be incredibly beneficial, especially as we launched the program. It provided a high level of assurance and comfort for our parents. It also eliminated geographical constraints. A lot of our families, as many of yours do, work, and so their access to healthcare, access to mental health, and also eliminated the financial burden for many of our families and transportation burdens for many of our families. A lot of our external referral for mental health and or supports, I think we only had about a 58% participation rate. And the reason for that, most commonly cited by families, was the inability to get their child to appointments on time within the constraints of their work schedule and the schedule of the therapist. Again, as I mentioned, there were no cost constraints for our families. It's provided at no cost to them. We did leverage our ESSER dollars to help support the program for the first 2 years. And we also love the fact that we, as it states there, there's a great diversity of Hazel providers. And I will tell you that from its inception, their program support staff who've come into our buildings have been incredibly beneficial. As we launched the program, we were training our nurses, and one of our nurses hadn't yet completed the program to be able to offer the system within her school setting, but she recognized that she had a student that had she just sent that student home would not get the healthcare support that he or she desperately needed. And they actually reached out to Hazel. Hazel immediately dispatched a support staff team member to the school, completed her training on site, and actually supported that family to get that child seen in real time. So we had some amazing success stories. Next slide. And we learned a lot from our implementation, as many of you will, or as many others have. First and foremost, how do you incorporate this within the union? We were able to work very collaboratively with our union to identify the current job duties and responsibilities for our LPNs and for our school-based nurses and show the correlation there. There were some initial concerns that we were going to turn our school settings into walk-in clinics. That is not what's happened. In fact, we've seen more at-home utilization, which means instead of families sending their children to home with a fever or symptomology, they're actually keeping them home, having early morning appointments, and keeping them off the campus. So we were able to track that data and use that with our union, and we keep them, we collaborate very closely with them to ensure that the usage is appropriate. Staff have been very encouraging, and again, we had some very early on, we had some great champions for the program who went out amongst their collective group and would share these early experiences and how successful it was. So even those reluctant adopters very quickly came on board, and we've seen our utilization more than double, if in fact triple, over the first few months of its implementation. I think it's also important to be incredibly transparent. We workshopped this publicly. We provided a great deal of information. Hazel was very supportive as well. They gave us materials that we could use to communicate with our families in multiple languages. And so we were able to send that information home and give parents the opportunity to kind of buy in over time. And our building principals were also provided with information from both the district and through Hazel so that they could market it. It's one thing for a school district to send home communication to families. It's something completely different when the principal, who has a relationship with a family, communicates directly with their families. And so we had a multi-tiered level approach to this for communication and to get participation. And what we have found through social media, parents are sharing their stories. And it's been incredibly impressive and incredibly beneficial to the overall program that parents are saying, I have a physician, we just couldn't get an appointment, so we utilized this. This was amazing. And they're out there marketing the program actually probably more efficiently than we have been. And sadly, as anticipated, based off the number of cases that we're seeing and the number of referrals that we're seeing in our data, and Hazel's very good at providing us with our regular updates as far as utilization, there is an affirmation of the need. And so we were very much on point with what we anticipated to see here in Polk County Public Schools. But again, it's not something you want to have come, it's kind of like that null hypothesis. You're hoping it's not true, but it turned out to be true. So next slide. So impact on students. Here's a couple quotes from some of our students and from a Hazel provider. It's important to note, again, the immediacy of access, the fact that parents get, one parent in particular who I'll let you read through these, went on social media, was incredibly positive about the program and said that they got a better report from the Hazel physical health provider that they've ever received from their child's pediatric physician. That it was incredibly thorough, it was incredibly detailed, and it provided them not only with answers to issues, but also next step suggestions and how they could communicate with their regular pediatric physician about next steps for their child and their treatment and symptomology. So again, from my perspective as a school district superintendent, it's been incredibly beneficial. And quite honestly, given the nature of staffing shortages and everything else that we're seeing, the high volume, the high demand, to make this as convenient as possible for our families and our students has truly paid off for us. And it's something that we look forward to continuing into the near future. Next slide. So by the numbers, 113 participating students, 24% of our elementary students have participated. We had 469 visits since our October launch. 49% of the students participating are middle school age students, and 12 years of age or older is the average intake age, and 27% of our participants have been high school. This is for mental health alone. We did not anticipate initially, especially in light of COVID and what we were seeing with inaccessibility to appointments and clinics. We expected to see our physical health numbers be exceptionally high. we were very surprised to see the number of mental health referrals that were occurring. And the one piece that's not in here, and hopefully Hazel can provide this at a later date, the percentage of home initiated mental health appointments is higher than school-based referrals, which tells us that parents are far more receptive to mental health supports for their children than we had initially anticipated. So we were very impressed by the fact that more parents were reaching out, or students themselves, high school age students. We have several cases where the student themselves reached out for assistance with their parents' consent. So it's important that I elaborate on that or accentuate that, because it was something that we did not anticipate to happen as quickly as it has, or at the volume in which it's occurred. We knew that we would have mental health utilization, but not at this level. So thank you for the time this morning.
Thank you, Superintendent Hyde. And next we'll hear from Director Bledsoe from Puyallup.
Good morning. It's great to be with you this morning. I'll just tell you a little bit about myself as it brings my lens of how I look at this work. I was a classroom teacher for 24 years and then an elementary assistant principal for 3 years. And I'm currently the director of social emotional wellness in the Puyallup School District. So what I'm hoping you will walk away with this morning is that idea that everyone, all of our students, should have access to quality mental health services, and that in order for our students to access that quality mental health care, it really needs to be part of a tiered system of support within schools. So I'll tell you a little bit about how we've accomplished that here in Puyallup. Before that, though, I'm going to set the stage a little bit with our location, and there's really two reasons that I want to share that with you. Is one, you probably haven't heard of Puyallup, Washington, but also that in terms of how we implemented this program, it does actually have a direct impact. So we are located about 37 miles south of Seattle and 33 miles north of Olympia, the capital. And I would like to acknowledge that we are coming to you from the land of the Puyallup Coast Salish this morning. So our community has roughly 43,000 residents. And typically, if you look over some information that's available from our City Chamber of Commerce, we're a pretty upper middle class community. And I'll explain what all of that has to do with our implementation plan here in a moment. The largest employers in this community are the school district and our local hospital. So we have lots of school folks here. So we are the 7th largest district in the state of Washington. We are currently serving approximately 22,500 students in our 34 schools. And this is just a little bit more information about our district. I think the important part here that I'd like to highlight is really how our district has changed over the past probably 20 years. So we'll look at that a little bit differently. So for example, here's our free and reduced lunch rate over the span of years. And so what that indicates is that we have movement and our community is changing, and not all members of our community are aware that our community is changing. So if we also look at our student demographic population, so each bar represents our total number of students, and then you can see our demographics are broken down. For the most part, our largest group of student population are white students, but each of these categories are growing over time. And also something that not all of our community members are aware of and think about in terms of what that might mean about what schools provide and how we go about working with our families. So when it came time to address how we were going to recover after the pandemic, our district created an academic and student well-being recovery plan. And one of the key things that happened is a survey went out to our community to ask them how they would like to see the school district prioritize our recovery efforts. So the survey was answered by almost 3,800 of our families. And 85% of them indicated that they agreed or strongly agreed that the school district should provide mental health services and supports. So this has been a really important key piece of data because in all transparency, not everyone is on board with the idea of mental health services being provided through schools. And yet having a number like that within our community is asking for these services, that's a really powerful communication tool and helps set our purpose. So it isn't, our plan isn't, Michelle Bledsoe thought this was a good idea. This is our community asked for this, and here's how we're responding. So I have a few other numbers I'd like to share with you. I think we already talked about a little bit. Before the pandemic, 20% of our students lived with a mental health condition. And in our local children's hospital, they saw a 400% increase from 2014 to 2018 in the number of children who are admitted to the emergency room for mental health emergencies. So that's well before the pandemic. Then during the pandemic, we had with a 67% increase in the medical admissions for mental health reasons at our local children's hospital. So while we see the impacts at school, and Superintendent Hyde talked a little bit about the impacts of what behavior looks like, but also in our community, families are experiencing that beyond school. So our not only our hospitals, but also our local providers are seeing an increase in request for services. So this has been touched on just a little bit, but the factors were the same for us here in Washington, that the barriers for families to be able to access that mental health care was really the availability of providers. And we heard from families that heard from providers that the wait list was anywhere from 6 months to a year. So that is a very big ongoing challenge. The financial resources to be able to commit to ongoing mental health care is a challenge. Transportation when families are working is a challenge. The impact to the work schedule for the adults who support our students. And then also just the stigma about asking for help. And I think if you reflect back to what I said about our community changing, so that's one of the things that's has been a common theme here, is that students and adults find it really difficult to ask for help. So a communication strategy has really been around reducing the stigma of mental health help and asking for help. So it might be something to consider as you roll out a plan in your community. So there's research that tells us that when students are able to access mental health services as part of a multi-tiered systems of support, that we can see measurable outcomes. And that support can be through Tier 1 preventative programs, or also Tier 2 and Tier 3 interventions. So I'll tell you about how that looked here in Puyallup. So the tiered systems of support idea is not new in schools, and it's also not new in medical professions or even among counselors or school social workers. And typically, we can expect that 80% of students will be successful with the Tier 1 core instruction, and 10 to 15% of students might need some targeted interventions, and then 1 to 5% of our students might need some intensive interventions. So after the pandemic, though, there's some experts that anticipate that those percentages are going to look more like 30 to 35% of our students will need targeted interventions, as opposed to the 10 to 15. And that is as much as 10% of our students might need some intensive interventions. So that's what we were thinking about in creating our plan for moving forward. So overall, as our district academic and student well-being recovery plan was formed, we hired a counselor on special assignment to support K-12 counselors. We have 54 school counselors who really are working on comprehensive Tier 1 school-wide school counseling programs with some Tier 2 interventions as well. This year, we were able to hire 4 social workers, which were brand new to us, a behavioral health navigator. And then we have had historically a number of outside partners who work with our students in mental health, and most of those have therapists who come on site into the school district. So let's see. So in tier 1, and that's really what we offer to all of our students, we have core instruction, second step, and character strong for social emotional learning curriculum. This year we added panorama surveys, which gives us some student input on their well-being. We just had our first data cycle in December, and that's now going out to buildings. So they're working on, each building is working on their school improvement plan and how this data can inform that. So we've had a big focus on positive school and classroom climate strategies, those really important things like greeting students by name, making sure that school staff are highly visible in the hallways before and after school, at lunch. Those are always good practices, but particularly important as students are re-engaging back into school. So for us, in tier 2, that's where Hazel Health fits in. It is a service that is available to all of our students, which is an amazing thing to be able to offer our families. So along with that, in tier 2, there's also small group instruction, which our counselors might be doing, or some trained staff in school buildings, and then additionally, maybe mentoring programs and some other more personalized touches. And then tier 3, we continue our existing behavioral health partnerships with other agencies in our community. And we have our local county has given grant money to those agencies to continue to support that work. So that's not a cost to our school district, but it is a really amazing service that we are able to offer our families. So in order for that multi-tiered system of support to be successful, it has to be a whole integration of all of those parts. It's not just tier 1, not just tier 2, not tier 3, but that our purpose is to create a school culture and climate that promotes wellness of all of our students, and then have the resources available to help the students who need something a little bit more. And in this day and age, to be prepared that we have more students than normal that need a little bit more. So Hazel has been able to increase access to mental health services, first of all, by just being even available for all of our Puyallup School District students. Some of the features that were really important to our community was that while Hazel isn't a local company, but the mental health professionals are licensed in our state. That was a very, very important talking point for us. And that typically a response is 3 to 4 days from when a referral is made. And then it might take a little bit longer to schedule the intake, but compared to when families hear that the wait list might be 6 months to a year, 3 to 4 days is, they are very happy to hear that. And that has definitely been our experience. The other part that is really important here in our community is that those appointments are available from 7 a.m. to 7 p.m. from school or from home. And just like in Polk County, actually our mental health appointments, we have more of them happening at home than we do in school. And some of that is with our COVID protocols and how students have had to be spread out in schools. Not every building has a dedicated space to where students can have a private meeting. So in some buildings, it really works best when families opt to have the appointments at home. But I think it also speaks to the fact that our families want to be involved in the mental health of their children and want to be partners with us in that process. So far, based on our numbers, the most common reasons that students are asking for help, and actually this is between Hazel and also our other behavioral health partners, is for anxiety, stress management, depression, and working through relationships. And our students say that their family relationships are the area that they need the most help with, and that's in our community is something that is hard to hear. Just a little bit of feedback that we've received is one therapist shared that she'd been working with an 18-year-old student who had never had counseling services before, and that through the Hazel Health Counseling, the student was able to really discuss her experiences, gain a better insight about how those experiences have impacted her emotional health and well-being. And she is experiencing a greater sense of comfort in school with herself and regaining some trust and confidence in herself. So that has resulted in less anxiety and less symptoms of depression and 0 panic attacks since completing those sessions. So in another situation, a Hazel therapist did an intake with a parent, and the parent actually was pretty hesitant about whether or not her 12-year-old would even be willing to talk to somebody over on a computer screen. And she sent an email afterwards to really thank the therapist for how comfortable the therapist made her student feel, and that they were, she and the student were both really looking forward to their upcoming appointments. Something that's been great to see is that our students are taking their sessions seriously. We had one student who took notes during their sessions about coping strategies, and then ended up making a kind of a visual list to help themselves. And then they were able to share that not only with their Hazel therapist, but also with the school counselor. So pretty awesome to see how seriously students are taking the services. And then when we very first launched Hazel in October, I think our very first counselor who made a referral got a very excited email from a parent who was thankful for how quickly they were connected to services. And the counselor sent the message that she feels like being able to offer Hazel has been a great gift for our students. So then the last part I wanted to share about feedback, and I won't read this whole slide to you, but this was from a high school student who talked to her school counselor. And I think that student voice is so important to hear about how the services are impacting them. And what really stuck out to me in her statement was that she said, "It may be painful to admit, but my generation needs more resources like the ones I have now." So I think that is a powerful message to me, that not only our community is asking for mental health services, but so are our students. So some lessons learned for us here in Puyallup is when you start seriously considering Hazel Health, to talk about, our director of communication talks about sharing information in little sips. So not big chunks of information, but small pieces of information in as many different avenues as you can. And one of the things that happened for us is we were not successful in adding the medical services that Hazel Health offers because of some perceptions in our community about what those kinds of appointments might include. But so we only have behavioral health services here. So involving as many stakeholders as you can in the planning, to think about from the principal's perspective, from the counselor's perspective, even the nurse's perspective, and have at least a few members of each of those stakeholder groups be part of the thinking and planning for everything from communication to the practicalities of the rollout. So you might also be thinking about what spaces are available to designate for private sessions, because I mentioned that was a real challenge in some of, for example, some of our older school buildings that weren't designed in the same way that we build school buildings now. They don't have extra spaces. So what might your strategy be around that? And then also to think through who is going to carry out each role, like who will initiate the appointments and who checks the calendar. And then this year, not only with the high number of student absences, we've also had a high number of adult absences. So I would recommend making a backup, and maybe even a backup to the backup when the adults are out, because we unfortunately had a few students who missed their appointments because the two people who knew how to check for appointments and get students started were out of the building. So as much as you can prepare for those kinds of possibilities will make the program more effective. And then think carefully through the messaging plans around not only to each stakeholder, but in each school community. And if you know your community and you know what their concerns might be, whether it's about behavioral health or medical health, then you can start communicating those little sips early to help provide some comfort and familiarity with it, and that it's not a surprise. So we also have had some good feedback on local social media platforms that families have been really happy with the Hazel services. So here in Puyallup, we did also start really early October. So we have 220 students participating. We've had 875 visits since that October date. The average age of our students making full use of these services are 11. And then also, like in Polk County, most of our students are in that middle school range, but elementary and high school also fairly represented here. So thanks for giving me a chance to share our experience here in Puyallup.
Thank you, Director Bledsoe, and thank you to both of you all for sharing your experiences. There are a couple of big themes that came out from both presentations, and it's important to document and note that both of the districts have some similarities, but very different in terms of geography and opposite ends of the country. But yet common themes are the need is there across age groups, across race and ethnicity, across income status and insurance status. That implementation is key. And so having good planning resources in place to make sure that there's a smooth and seamless rollout. And the third thing is access continues to be a significant issue. And you've got to think through a diverse set of strategies to be able to overcome those barriers, to be able to get kids into the services that they need. And we are excited about Hazel being a part of that equation and look forward to continuing our partnerships with your respective districts. So I just wanted to, before we get into questions, provide a little bit of background information about Hazel Health and what we do and who we are. Again, I'm Travis Gales. I'm the Chief Health Officer for Hazel. And my background, I'm a pediatrician by training, and in my former practice used to specialize in adolescents and young adult medicine. Primarily those kids 13 to 24. And also, as I transitioned out of private practice, went into the public sector and most recently served as a health department director in Montgomery County, right outside of DC, up until last September through the COVID pandemic. And our health department was one of a few health departments across the country that actually oversaw school health services. So the experiences that you all are seeing on the ground were things that we worked very closely with our local school district to address. We also worked very closely with our Children, Youth, and Families department to come up with some creative strategies to get kids linked to mental health services. And as Director Bledsoe mentioned, yes, the COVID pandemic did highlight and exacerbate a lot of existing issues around the mental health space, but those issues were existing before COVID got to us, and the shortage of resources, both from an inpatient and outpatient perspective, were significant then, and they've been made worse now. And so we at Hazel Health look at this as an opportunity to step in and assist local school districts with being able to meet the needs of their school kids from a mental health perspective. Hazel Health is the largest and most trusted telehealth provider for K through 12 schools across the country currently. Our model is truly built on meeting students where they are. And again, based upon my background and the diverse team that we have at Hazel, both in perspective of race and ethnicity, professional experience, as well as experience in the private and public sectors, we truly believe in the whole child model. And in order to truly address that, we've got to think of it as addressing all of the different components that influences a child's ability to be healthy and to be present in your classrooms. We have a mental health component that we've talked at length about today. We also have a physical health component that Superintendent Hyde talked a little bit about as well. We have providers to provide, if you can think of kind of a sophisticated urgent care type model, to help triage children's physical health concerns as they come in and help link them to their existing medical home, or if they don't have a medical home, helping the families make those connections. I want to point out that even in situations where a district may have one or the other or both, our providers, both from a mental health perspective as well as physical health perspective, are thinking about the other bucket. And so when kids come into our mental health platform, we're constantly looking to make sure that if they do have any chronic health issues or any other acute issues from a physical health standpoint, that they are linked to services to address those and they are getting those looked into. And the same in return, our physical health providers are constantly thinking of creative strategies and ways to assess children who are coming in with physical complaints to determine if they do have mental health concerns that need to be addressed, and are providing referrals to our platform or to resources within their respective communities. And that highlights that third component, the care coordination piece, that we feel is important. We know that simply coming in for a physical or mental health visit is not just a transaction. Our intent is to be translational and impact the child's trajectory by being able to identify the needs that they may have that we find in those settings, and working really hard with our family resource managers to connect those families and children to resources in the community, so that, again, all of those different factors and barriers that we know can impact the child's ability to be healthy are removed as best as we can. And we don't just stay where we are and are stagnant in that. We are constantly looking at data to improve our practice and improve our efficiency, but also be able to identify best practices such as those that have been highlighted both in Polk County and Puyallup. To be able to share with others across the country so that, again, we can come up with more innovative strategies to be able to address our kids' needs. Next slide. Now, the other big thing that all of this feeds into is our belief that we really do have to be intentional about creating a culture of preventative health for pediatric health. Now, as a former practicing pediatrician, from a physical health perspective, this is heavily integrated. We tell our kids and parents, come in every year for their annual physical. Get your eyes checked every year. Get your teeth checked every year. We don't have a similar culture around mental health. We don't have routinized check-ins in terms of emotional well-being for our children. And so we're looking at how to develop even more strategies to increase those touch points for mental health check-ins. Again, our belief is that the only time that let me take a step back. Our belief is that the time in seeing a mental health provider should not be the only time you're asked about your mental health and emotional well-being. And we believe that there is no wrong door of entry within which we can help ask our children and talk to our children about how they're doing and how their daily lives are impacting them. We also, again, want to routinize those mental health check-ins as we do with physical health concerns, and are also interested in looking at how we can proactively identify children at risk as opposed to waiting for them to present in crisis with symptoms before we provide them with linkages to services to address their needs. Next slide. Now, again, this is consistent. We've talked about this already in terms of our approach in addressing the whole child. You can see our social determinants of health model, again, that both Superintendent Hyde and Director Bledsoe talked about in their presentation about all of these other factors that influences the child's health. And to the right of the slide, you can see all of the different pieces and services we have in place to help address the comprehensive whole child, not just the clinical encounter. Next slide. Now, one point I do want to highlight and was touched on a little bit in each of the presentations is the component of representation and why representation in health matters. When we look across the country, again, there's a huge shortage of mental health providers overall, but specifically within that, 20% of mental health professionals identify as people of color. At Hazel, just over 50% of our providers actually identify as persons of color. And this is important because we know that sometimes children will respond better to someone who looks like them. And it's important, given the diversity of all of our different districts across the country, that our providers meet the need and match in terms of the representation within those communities. And so this is something that we emphasize, and we work really hard to try to match children with therapists who have similar backgrounds, again, to create an environment that's conducive to creating a safe space for children to be able to express themselves. Next slide. And our mental health program to date, we've provided access to over 350,000 students across 6 states in just 6 months. That has in turn meant over 2,000 mental health referrals. And in February alone, we had over 1,000 mental health visits. And 70% of all referrals that come into Hazel lead to a mental health care protocol for the student referred. So this underscores, even in the early stages of our rollout and launch, that we have identified significant need, and we've been able to get children linked to therapeutic services in a much shorter window compared to the wait times that many jurisdictions are experiencing. Next slide. So just wanted to provide that overview of our company. Again, we've got lots of resources that our team is happy to share with you. But in the remaining time that we have, wanted to open the floor up for any questions that you all may have for our esteemed panelists. And again, thank you to both of you for sharing your story. And we are very excited and fortunate to be able to be a part of your journey in addressing your students' needs.
Perfect. Yeah. Thank you, Travis. And of course, thank you, Fred and Michelle, for sharing all of your experiences at your separate districts. So like Travis just said, we've come to the Q&A portion of our webinar, where you can now send your questions in to our speakers so you can have your questions answered live on the air. If you haven't already, just again, please send in your questions in by accessing the Q&A panel that we have on the right there, located on the bottom right hand of your screen. Okay, so let's see the first question that we have here. It looks like it's both for you, Michelle, and Frederick. So at your districts, how have you been able to support the mental health needs of students with underrepresented backgrounds and ELLs, or English language learners? Fred, you want to start?
Okay. Again, in partnership with Hazel, we provide translation services. And then what we appreciate about Hazel is after the initial visits, there's also a referral process. And so we have localized agencies who specialize or have the ability to support those students in their respective needs, whether they be language needs or other needs. And so the referral process then directly markets or directly sends students to those external providers. And then I think, as Michelle also spoke about, and I shared, the lead time for a new appointment can be upwards of 7 months here. But because of Hazel and the referral process, it's actually shortened down to just a few weeks, which is the longest duration that I'm aware of to date. So there is a benefit to having them essentially in process in the system and that partnership. So we're able to expedite those for those students and their families, especially EL learners.
Perfect. And you, Michelle? Oh, no, Travis, you want to go? You want to say something?
I was just going to add quickly that one of the components on one of the slides we talked about representation is approximately 40% of our mental health providers are multilingual, and just wanted to highlight that as well.
In our particular community, we have there's a lot of questions about whether or not the providers from Hazel speak different languages. So I was just talking with the analytics team at Hazel last week about looking at our data in terms of the demographic representation. So I don't have that yet. It's something that we're starting to talk more about. But I will say that we have families who have requested a provider that looks like their child because they think that that's going to help their child be more receptive to services. So I know that that's something that Hazel is continuing to work on to be able to meet that need.
Perfect, thank you. And let me just check another question. Just came in. This one is for you, Travis. This is a good one. Does Hazel offer similar services for teachers and employees, or is it only for students? It's a good question.
That's an excellent question that highlights a significant need as well. I know we've spent the entirety of our presentation talking about children, but the question underscores there is significant need for services for teachers and staff. As it currently stands, the Hazel platform is only for children within the school system, and we have. We continue to, explore other potential ideas, but right now, as it currently stands, the services are just for the children.
Perfect, thank you. Another question that we have here. How does Hazel address, social determinants of health, like transportation, health literacy, even economic stability?
Well, I can speak from a broader perspective, and then certainly would love to hear the insights from the local jurisdictions in terms of how they handle it. But the Hazel Health model, is built upon providing clinical services, but we also, as mentioned, have that care coordination arm. The care coordination arm includes a couple of different pieces. The first piece is we have a team of family resource managers, which mirror your typical case management type function. And when needs are identified as part of the physical health or mental health visits, our providers are trained to ask about those types of things, particularly as it might influence a child's treatment plan that's provided. And that information is shared with our firms, our family resource managers. And depending upon the community, the firms work closely with resources that are often already established within the local jurisdiction and community to link families to in terms of getting the services needed to address those concerns. And so that's the approach we take. It's more of a bridging and connection service to, again, link those families to those resources within the community. And so it's the firms linking families to those services, the clinicians and staff being proactive about asking and identifying those particular needs. And the third component is, and this gets to the data piece, is we're continuing to look at ways that we can make how we deliver services more innovative to address that, as well as identify those best practices and share with the broader community so that we're not only transforming how we provide services internally, but hopefully are changing the way that pediatric services are delivered more broadly.
Perfect. Thanks. Michelle and Frederick, do you want to kind of hone in on that question on a local level, or I can move on to the next question?
The only thing I'll add to what Travis shared was every school district already has a playbook that we provide our psychs, our social workers, our counselors for referral agencies and support networks and structures. And so very much as Travis said, it's a partnership. And so when we are informed and we're collaborating as it relates to a student and family who's in need, we have those resources readily available to make that efficient handoff process or provide those supports regardless of cost, regardless of need, regardless of their circumstance. And that's applicable to all students. So I don't know if we missed a part of the question, but I wanted to reaffirm what Travis said, that, at the district level, at the school level, all of us have that resource book we provide and update annually for our staff. So for families in particular.
Perfect. Thanks. Michelle, you want to add on to that? It's fine.
No, actually, I don't have anything new to add. Thanks.
Okay, perfect. And we're almost on top of the hour, but we'll ask one more question. Um, just came in. How do you vet your clinicians? So it says both those who do initial assessments and those who are providing ongoing and short-term services.
Well, um, as with any of our clinicians, whether they do physical health or mental health, we have a very rigorous recruiting process in terms of where, we certainly confirm that folks' credentials match up to their history and background, and that they're appropriately licensed in their respective state and they meet those requirements. But we also, we ask, questions about not only their ability to administer clinical services, but also about their ability to understand everything that we've talked about today, the whole child perspective, the influence of social determinants of health. Because again, we know that everything that impacts a child isn't just that transaction in that space. There's a whole host of other things that influence their ability to be healthy and successful. And it's important to us that our clinicians not only buy into that idea, but incorporate those strategies into how they deliver services and work again closely with other members of our team in terms of firms. But I see a question in the chat about what about existing staff and social workers. And to Superintendent Hyde's point, they also work very closely with the existing teams within schools. This is a partnership. I want to emphasize that this is not us coming in and just taking over services. It's coming in, being respectful of the infrastructure that's in place already within a school, developing those relationships, working within that framework, and partnering together to, again, be able to make sure that the child has the clinical resources available, but also is tapped into those pre-existing resources that are set up and there to help the child be successful.
Well, I'd like to add to that because it's something that Michelle touched on too, is when you look at your MTSS and your multi-tiered systems of supports, we also chose to go this route because it would allow us to tier services for students, which would then subsequently free up my staff because our staff to student ratio is not where it needs to be. So for my school-based staff, we can actually provide them the opportunity to touch more students and reach more students because there is this aspect of Hazel that can offload some other students who otherwise may consume an inordinate amount of time on their behalf. It doesn't mean they don't remain connected to those students and families. They actually do, but it allowed us to go deeper and broader with our student population and actually provide a higher level of service. And as I mentioned earlier, our staff have been incredibly, while some initial reluctance, have been incredibly positive in reaffirming us to our adoption in partnership at this time.
All right, perfect. Well, that's all we have for time for our live Q&A. And I do see that more questions were coming in, but don't fret. I'm sure that our partners over at Hazel Health, they will be willing to get back to your questions individually after today's webinar. I'll make sure to share that with them. And actually, as I go through my closing slides in just a few moments, please feel free to continue submitting your questions if any come to mind. So yeah, continue submitting your questions and we'll get to them after the event. But again, I'd like to, just thank you to Travis and thank you, Fred and Michelle, for your time here today. And of course, thank you to Hazel Health. And to you, our audience, I would also like to thank you for joining us today. For those of you who particularly enjoyed what you saw, there are many more upcoming web seminars like this one that are provided by District Administration, which is the leader in editorial coverage of news, trends, as well as current issues in K through 12. We have a wide range of readers here at DA who subscribe for free, and they stay up to date with us through our print magazine, newsletters, online, and webinars like this one. Also, last thing, if you would like to watch this web seminar again, or for those of you who believe that the solutions that were provided today would be particularly helpful to your colleagues, you will be pleased to know that our team at DA, we will be sending you an email at some point later tomorrow with an on-demand recording of this web seminar, as well as a link to the slides. So with that, on behalf of DA, this is Stephen Blackburn. Thanks, everyone. Take care, be well, and stay safe. Thank you again.